Abdullah, sorry.
Thank you, Dr. Sundus, for the kind introduction. Thank you, organizing committee, for the invitation. So I'm going to talk about case approach to compromised side branch. So a 70-year-old male known to have diabetes type 2 hypertension, moderate aortic stenosis, aortic valve area was 1.2 with mean grade of 33 millimeter mercury. He had actually PCI done to LAD in 2014 and PCI done to RCA and PDA in 2016. This is his angiogram done early in 2016, showed basically severe narrowing in the mid-RCA and spot focal area in the PDA. And the LAD was a stent relatively patent, and the outlet of the stent was diffuse lead disease. So at that time, actually, he underwent PCI, initially done to the PDA using a 3.0 by 15 millimeter stent. And another PCI was done to the mid-RCA using 3.5 by 50 millimeter regulated stent, and at that time the results was satisfactory. The LAD was managed medically at that time. So after that, the patient actually he lost follow-up and presented to our center in 2021. He came to us with the non-STEMI, and at that time echo showed basically reduced ejection fraction. New onset heart failure ejection fraction was 35%. So upon asking the patient, apparently he had TAFI that was done with two self-expandable valve, evolute, at the same index procedure. At that time, the patient basically, according to the report, that the first valve actually was partially or deployed higher than it should be. Then they put a second valve just to fix the first valve. So when we did echo for him, basically the mean gradient above two valves actually was reassuring, 60 millimeter mercury, and there was a mild paravalvular leak. So at that time, we didn't blame actually the valve for his presentation of the non-STEMI. So you could appreciate that the two cells of the two valves appeared in the angiogram, so we couldn't engage the left system using JL 3.5 guide catheter. We try also with APU 3.5, we couldn't engage two. So upon non-selective injection, you could appreciate still the stent is patent, but we cannot see clearly that distal to the stent. At this point, after multiple trials, we couldn't engage the RCA. So we did aortogram, and you could appreciate in the aortogram that the distal RCA, actually, the stent is patent in the mid segment, but we could appreciate there is probably bifurcation lesion here around this distal RCA. So general recommendations for cannulation of patient post-TAVR to start usually bifemoral approach. It's going to be easier. Aortogram might be done just to delineate the coronary artery in relation to the valve. Then using guide catheter is recommended rather than using diagnostic catheters. Simultaneous injections and manipulation is going to help you to support. Now using of 0035 J-tip wire is going to help by push and pull maneuver with the catheter that help to get coaxial with the ostium. Now, if this failed, basically advancement of the catheter cell through the valve cells to get the selective position, and if all that failed, non-selective wiring, it might help also using anchoring balloon or extension catheter. So in our patient, we tried 6 French, JR4, IM, multi-purpose, nothing worked. Non-selective wiring, nothing worked. So we went with a 5 French JR4, and we could see clearly that the distal RCA basically at the bifurcation of PDA and PL branch is actually the culprit for his non-STEMI. Now, compare this to angiogram done in the RCA in 2016. So this is a super dominant RCA. You could appreciate how large the LPA branch and the PDA, and also by looking at that, you could appreciate this is a long lesions, good diameter, at least 3 millimeter on both sides. And with the possible occlusion of mid-LAD, this is probably give some collateral to that mid-LAD. So this is very important bifurcation. Ideally, if we're going to look based on the recommendations from Eurointervention, this is Medina class 111, and this has a non-lift main with a side branch stenosis more than 90%, more than 10 millimeter side branch. There is probably some thrombus to explain this haziness, and the lesion more than 25. So it's a complex lesion. Probably having two-stent technique here will be a better option. However, either DK crash or any two-stent technique will require 6 French But in this case, we couldn't give anything other than 5 French. So based on what we have, we decided to go for basically provisional stenting for this patient. So we wire initially the PL branch. We couldn't wire the PDA branch, so we balloon inflated 2.5 by 15 millimeter. Then we could actually wire the PDA branch, and we ballooned both branches. Now, this is basically what we got on the left side. So this is true bifurcation, and this is a big territory. So our plan was to go provisional. So we start basically to do DCB initially to the PDA branch using 3.0 by 25 millimeter balloon. And then we put a drug-eluting stent, 3.25 by 33 millimeter, and we chose this branch actually because it's a bigger relatively to the PDA. Immediately after stenting, clearly we lost the PDA branch, and luckily this patient doesn't have any chest pain, blood pressure was stable, and no CG changes. So again, back to the recommendations from neurointervention. If you have a jail side branch, deserve further intervention, you have 3 options. The first option, you do kissing balloon inflation to both branch. The second option, you do kissing balloon inflation followed by repot. And the third option, you do side branch dilatation, then basically doing repot, or what we call pot, side pot. If that failed, what you're going to do, you have to do a side branch stenting. In this case, because we're using 5 French, we cannot use kissing balloon. We cannot use, again, kissing balloon followed by pot, and we cannot use side branch stenting. So we lift up by having side branch dilatation followed by repot. So this is where the recommendation came for this basically technique. It was actually first time to be published in 2018, and around 106 patients. They have through bifurcations, and it was basically was OCT-based study. So they did 3 OCT runs before stent implantation, then after stent implantation, then they did basically the technique by doing initial pot followed by side branch inflation, then final pot, and they did the final run of OCT. And there are different, you could appreciate left main, LAD diagonal, circumflex marginal, and RCA PLA. So based on the OCT results, this repot technique actually restored optimal bifurcation geometry, reduced overall strut malapposition, reduced strut obstruction of the side branch ostium, and provide very good, actually 6-month safety. So back to our patient, we did initial pot by 3.5 by 12 millimeter. Then we did the rewiring of the PDA. We did side branch dilatation. And after that, actually, we did the final pot using 3.5 by 12 millimeter. And this is actually didn't work. So the final result, we accepted the final result because we don't have any option at this stage. But luckily, the transthoracic echo done 2 months later showed basically this patient has recovered LV ejection fraction from 35 to 45. And 1 year later, he presented with chest pain, and you could see the branch actually was patent again. But what's the problem this time is this patient has again ISR in our stent. So what we did at this time, we did an IVAS that showed nodular calcium that was managed with the IVL shockwave 3.5 by 15 millimeter, then DCP 3.5 by 20 millimeter. And after that, we get the final result as I'm going to show you in the next slide. So my take-home message with the growing population of TAVR patients, coronary cannulation and post-PCI TAVR could be challenging. Commissural alignment is very important during any stent expandable valve, allowing for easier coronary access. And whenever using a valve, try to use 1 valve for every patient. Talking in general, provisional stenting, pot side pot is a simple and safe technique. Once yield, the side branch is recognized. And the only advantage, in my opinion, in this technique is basically could be used with a 5 French system easily. Thanks for your attention.
Thank you, Dr. Abdullah.